my first choice. That one.
All right. Well, we're going to get started. It's so awesome to be here. My name is Adam Brown. I am a doctor by training, emergency physician by training. I work at Envision Healthcare. We're one of the largest medical groups in the country. We have 35,000 people that work for us, 25,000 of which are clinicians. And we work in over 45 states around the country, taking care of more than 32 million patients a year. So needless to say, the last 2 years have been somewhat busy for us. We'll get to talk a little bit later about COVID and the Omicron, oh my God, whatever you want to call it, variant. I've got some slides and things to share with all of you for that. We can kind of frame some of that out. But before we get to that, which will be in an hour, more importantly, we want to talk about what happened yesterday. And that was World AIDS Day yesterday. And really want to talk about and have this really amazing group of panelists who I'm going to bring up in just a second to talk to you about the imperative that we have to still take care of not only these patients, come up with solutions for taking care of these patients, for preventing this disease, because more than 40 million people around the world still, over the last 40 years, we still have 1.3 million people here in the United States. So it's a very significant type of issue that we still need to deal with. And there's a lot of pieces and parts to this discussion, because just preventing and just treatment are not just the only things that are working for taking care of this disease. So I'm really looking forward to this discussion. Now, some may ask, well, why in the world are we having this discussion within the business? Well, one of the ideas behind the Center for the Business of Health was to bring together many different parts of the school, from public health, from pharmacy, from medical schools, from the business school, all the different thought leaders there, and the ideas around there, to really drive change in healthcare, because it can't just be a business issue. It can't just be a healthcare medical type of issue that's driving change in healthcare. It really has to be all of these different individuals and stakeholders pulling together to drive impact and drive change in healthcare. And this is an excellent discussion here and an excellent issue and topic for us to discuss here, to show how, from an interdisciplinary perspective, we can start to make change in a positive manner, especially with this disease. So that's the reason why we're here. As we continue on, and as we continue on this discussion, I want you to, as students, as thought leaders, as executives, as leaders in healthcare, to be thinking about what are the opportunities, what are the problems, what are the pain points that may be experienced by patients, by providers, by public health officials. Where can we get involved? Because we all have a role to play to improving not only the healthcare around this disease, or around people that have this disease, but about all of the diseases that we take care of. And here in North Carolina, and even outside of North Carolina, we certainly are seeing, especially now with COVID, the effect of social determinants of health and how that affects the healthcare of our friends, our family, our colleagues. And so as we talk today, I want you to be thinking through that as a frame of reference to how do we drive some of the changes. So before we get there, and I just will be full disclosure, it's maybe a little wonky because we've got Zoom. We're going to have some questions, some interactive questions coming through with Zoom. And so I'm going to be trying to play both the role of the producer technician as well as the moderator in a second. So bear with me there. I've been sitting in an office at my home for quite some time, only having all the command and control in front of me. So we're going to do a poll first before I introduce the panelists. So this is a Menti poll. I hope everybody online can see it. You guys can see it here. So you can scan the QR code. If you're at home, you can also scan the QR code, or you can simply go to menti.com and add in the code 85752824. Okay, so give me some thumbs up. Good, good. Okay. So first question, for those who may not be able to see it, depending if you're driving or what have you, is when someone mentions HIV or AIDS, what words or images immediately come to mind? A big part of our discussion today will be around stigma. One of the top words. You can answer more than once. All right, so something that's coming out is stigma, blood, death, taboo, LGBT, Black, sexually active. A lot of different words here and images come to mind. I'm not seeing any positive images. If I were to change that word HIV with diabetes or heart disease, how would these words change? I think that's something to consider as we start to talk about the solutions, because a big part of the reason why the disease is continuing, and why in many parts of the country, South actually in particular, the disease continues and continues, even though some communities it continues to decline. So let's go to one other question before we move to our panel discussion. So name social and structural determinants of health that drive healthcare outcomes and inequality. So for the business folks, this is your slide. These are the problems that we've got to fix. You can come up with all the greatest drugs. You got to fix these. So access to healthcare, access to prevention. I hear that word access a lot. What does that mean? We'll talk about that. Lack of health literacy. I also love that word. That's a soapbox of mine. When people talk about health literacy, what is the converse of that? Illiteracy, right? Do most patients think that they are dumb and illiterate? No. Most patients consider themselves quite knowledgeable about their body and that they have done their research. So remember that when we think about people being illiterate or literate. They just may be uninformed. Systemic racism, education, gender, fear, income, race, access, excellent. And you'll notice that even with the Surgeon General over the past year, and in a lot of the different initiatives coming out of HHS, the Health and Human Services, has been the need to focus on social determinants of health as really the way that we change all diseases, especially with HIV. So I wanted to start these as just a part of a conversation starter, something to frame out the discussion that we were having today, and why we as business leaders and future business leaders are things that we're going to have to think about as we come up with fixing the challenges of not only healthcare broadly, but also of HIV. So without further ado, I would like to bring to the front Katie Grimes. And then have you introduce yourself. Would you get up here?
Oh, we're one at a time.
Oh, no, you guys are.
We'll just sit alone.
Yeah. Sorry, this is not my normal setup, but like a big say, Rashard Conrad and Derek Matthews. All right, so I'm going to go off the stop share.
I know. At
All
myself.
right. Yeah, so let's go ahead. Go ahead and introduce yourself.
Hi everyone, my name is Katie Grimes, she, her. I am a first-year PhD student in health policy and management over at Billings. But this is my second time here. I got my master's in public health and maternal and child health back in 2014. And I have been practicing public health for a little over 10 years now. Most of my projects are based in sub-Saharan Africa, so I'm going to be bringing my experience working on global projects into this discussion today. I have worked on a number of non-HIV projects as well, which I won't get into the details there other than to say my interests are for sexual and reproductive health in general, as well as infectious disease detection, prevention, and response. Now, the HIV work that I have been doing most recently has been within military populations, primarily in Francophone West Africa, but I have an ongoing project in South Sudan, supporting the South Sudan People's Defense Forces in their HIV care and treatment program. Now they treat both military and civilian populations. So I'll be speaking a little bit about that as well.
Great, thanks. And Derek.
Hey everyone, my name is Derek Matthews. I'm an assistant professor over at the Gillings School of Public Health and Health Behavior. And I too got my degree here at UNC in 2013 and came back about 3.5 years ago. So my research is primarily interested in the domestic epidemic in HIV and really with a focus on the racial inequity primarily among men who have sex with men. And so I'm really interested in kind of what are those drivers that kind of sustain and kind of create and perpetuate the racial inequity there. You know, I also do a lot of kind of non-infectious disease health inequities work in LGBTQ populations broadly, but the reason I kind of keep coming back to HIV, and I think all of us will discuss today, is it's really kind of this unfortunate perfect storm of kind of a lot of the problems that we face, you know, kind of not just in the US, but globally. And so HIV really, I really do firmly believe that if we can really kind of get a handle on understanding and interrupting those processes that kind of fuel this epidemic, that we have, I think, a pretty good shot at kind of making a lot of strides with other health problems as well. So thanks for having me.
Sure.
All right, good afternoon. My name is Rashard Conrad, and I'm bringing my experience from the standpoint of advocacy and working directly with those who are living with HIV. So I'm the founder of Breaking HIV Stigma, which is a social media platform and soon to be nonprofit, where the goal is to increase the engagement around education, resources, prevention, as well as treatment. I've served as I'm the former assistant director of early intervention services at the Alliance of AIDS Services Carolina, as well as I've worked as a patient navigator at Wake Forest Baptist Health. So in both of those roles, it really kind of consisted of working directly with the clients to help get them linked to care when they were newly diagnosed, or trying to reconnect to care, and just helping them to get access to those resources of medication access and things of that nature.
And as I mentioned, I'm Dr. Adam Brown. Just please call me Adam. I am an alum of the MBA program here at UNC. I'm our co-chair at the Center for Business of Health with my friend Francis Nahas for the leadership board. I'm also on the Next Gen Board of Advisors for the business school here. And then, as I mentioned, I'm an ER doc, but I'm our Chief Impact Officer also at Envision Healthcare and oversee our COVID response. So, and of course, have taken care of a lot of patients with HIV. So we'll start with you, Katie. And I just think your background is really fascinating because you have worked in really the origins, the beginnings, or of where a lot of we see so much structural racism, lack of resources, huge inequities in Africa. So give us some perspective on not only what your experience was there, but also just where we stand globally.
Yeah, so I think it's important, at least at the very beginning of this discussion, to have a bit of a primer on how we're tracking progress. So the Joint United Nations program on HIV/AIDS, which is UNAIDS, they set a goal several years ago to end AIDS by 2030. So how do we measure whether or not that's going to happen, right? And so they set what they called the 90-90-90 targets, which later became the 95-95-95 targets, as a way to track progress both globally as well as on a country level to see, okay, are the programs that we're implementing actually helping? So what are those? It's also known as the treatment cascade. So the first 90 or the first 95 is that 95% of people who are HIV positive know their status. So getting at that testing and awareness piece, right? And then of those that do know their status, 95% of those people are on treatment. And then that third part of the cascade, that third 95 is of those that are on treatment, 95% are virally suppressed. Now, why is viral suppression important? So there is this big push, it's U equals U, or undetectable equals untransmissible. And that basically means that if someone is adhering to their antiretroviral therapy, if they're consistently going to their appointments, then their viral load is low enough that they won't be able to, or it would be a negligible risk to transmit HIV. And so if we're thinking about epidemic control, all three of these pieces are really important, right? And so HIV care and treatment programs can target different aspects or all three parts of that cascade. Now it's 2021, how did we do? UNAIDS just recently came out with a report that demonstrated what our progress was. I did not memorize everything, so please forgive me for bringing some notes. But globally, we did not reach the 95, 95, 95 targets, but I think, we came pretty close. So for that first 95, 84% of people living with HIV knew their status, 73% on treatment, and 66% were virally suppressed. And it's pretty interesting to think about also the geographic variations, right? So you were mentioning resource constraints, and I think that that's huge. And I do want to talk a little bit about Eastern and Southern Africa, because that's where I work now. It's also the area in the world that carries the greatest HIV disease burden. And if we think about it, worldwide overall prevalence of HIV is 1.2%. North America prevalence is 0.6%. And then in sub-Saharan Africa, it's 9%. And then if you narrow down even further to certain countries, within Eastern and Southern Africa, that region within sub-Saharan Africa is carrying the greatest disease burden, as I mentioned. And Eswatini, which is a country in Southern Africa, their prevalence is at 27%. 27% of the population is HIV positive. And so if we're looking at the differences in target achievement, like globally, we've done pretty decently, right? Like we didn't hit 95, 95, 95, but new infections were reduced by 52% since the peak of the pandemic in 97. And AIDS-related deaths were reduced by 64% since the peak in 2004. And we look at the achievement in Eswatini, which it's pretty remarkable. They were able to achieve 98%. They surpassed the targets. 98% knew their status. 98% were on treatment, and 97% were virally suppressed. Like, that's amazing. And then contrastingly, we look at South Sudan, which is predominantly where I've been working, and their achievements were 29% knew their status, 23% were on treatment, and we don't have data on viral suppression. And so you think about the experiences in these different countries. And for those of you that might know a little bit about the history of South Sudan, they're the newest country in the world. They achieved independence in 2011 after quite a bit of civil unrest with what is now just Sudan. And that civil unrest continued. I think the violence really sparked up again, I think in 2013. And so you think about like, okay, what is a result of civil war, violence, conflict? I think 7 million people are food insecure. It's been really difficult for us to even be able to travel there, And so if you're looking at the different experiences within these different countries and the constraint of resources, I think for our program in particular, our biggest challenge is human resources. So South Sudan People's Defense Forces, we have PEPFAR funding, so US government funding. We can't pay salaries. And so what we're hearing from our partners is you need to help us pay salaries, because none of the health providers are going to come to work if they haven't been paid in 6 months, right? And so I'll pause here for now because I've been talking for a while, but definitely when we start talking about equity And like where there is discordance in expectations from the donor versus what the actual needs are on the ground, it's been very challenging.
Well, you mentioned donors. I'm going to go to Derek with you because a lot of people in the past have seen HIV as almost a charity, meaning that there is a support this HIV charity. But why is that a problem?
Yeah, thanks. I really, I've always found that framing really problematic, and it's the one I think we commonly do. And it's not even that people don't mean well, right? But the issue with charity is it, by definition, sets up this really problematic power inequity, right? It's those who have, kind of giving to people without. And I don't think charity is the framework we want or we need if we're going to be serious about eliminating this epidemic, right? It needs to be a framework of kind of justice and equity and public health. And so, the reason we need to, I think, really get a handle on the HIV epidemic, don't get me wrong, I'm not mad if people feel good doing good things, right? But that's not the motivation, right? The motivation needs to be kind of thought through a public health lens, and how do we kind of really achieve these targets that, right, we were just talking about. And the way to do that will never be through kind of this ad hoc charity lens, right? It needs to be, how do we kind of create the sustained response that we need and at the level that is required, right? We'll never really kind of achieve these targets with these piecemeal ad hoc things. It's really a lot more structural, and how do we invest in kind of not only state systems, but kind of community-led efforts that are really in the best position to kind of really get a handle on this. And so again, that isn't, charity is not the solution to that.
To Katie's earlier point about resourcing, I mean, we obviously have resourcing issues here in the United States as well. And so from a domestic perspective, I'd love to hear your thoughts. We had a question up about social determinants of health and resourcing is a part of that. But speak more, because you're a public health expert, like speak more about as well. So speak more about where you are seeing how social determinants of health, first, what are they? I want to make sure everybody knows what they are. And then second, how is that playing into our treatment, prevention, and then eradication of the virus?
Yeah, so, it sounded like people kind of had a general understanding based on the poll, but just for those who aren't familiar, it's kind of our, fancy academic way of saying that these are the things kind of that exist in the social, the environment, economic, that are responsible for kind of, producing health that kind of exist outside individuals or exist outside of kind of medical concerns. So, I saw housing, education, racism, income, early childhood opportunity. These are all kind of classic social determinants of health. And, just before, I know it's really easy to kind of dismiss these as like, well, yeah, that's nice and good, but like they're squishy and like, we're just really concerned with like individuals. Like, so, I'm really primarily concerned with, like I said, these racial inequities in HIV infection. And, I'm primarily a quantitative researcher. I also kind of am like those squishy topics, right? I don't have time for that. But if I tend to, honestly think of a lot of my work kind of through like equations and math and what makes sense, right? And so, social determinants are important because like we need them to make the world make sense, right? So for example, compared to kind of white men have sex with men, Black men have sex with men, right? Or something like anywhere between 4 and 6 times more likely to become HIV infected for every active condomless sex they have, right? And so the same behavior, right? But
It's
what's
not because of one being Black and one being white. It has to do with all the other things. For us.
Exactly, right? So there's nothing about like the amount of melanin in my skin, right? That's like making me biologically more susceptible to HIV infection. It's really about, well, it asks us to really think, not just what puts kind of individuals at risk, but what puts kind of communities at differential risk, right? And social determinants are really the framework that we need to think through. And so, the reason it's such an important thing to think about in terms of where we invest resources is you can think of it kind of like whack-a-mole. It's like we can try to hit each one individually as long as we want, but like we have to get a handle on it entirely together, or we're never going to kind of really sustain that progress. If we can, get treatment in the hands of someone, that's great, but if they don't have somewhere to kind of live, like, like we haven't really solved the problem, at all. So that's the perspective that the kind of social determinants of health is really helpful for in getting us a handle on how do we kind of make sustained and permanent progress.
Yeah, I want to dig into that a little more. So more specifically around HIV, what are a few of the big things that you see are social determinants of outcomes? And when we say social determinants of health, we're talking about outcomes, right? We're talking about either someone not getting HIV, someone's life expectancy, and then some of the things that you had mentioned, Katie, about like how transmissible are you undetectable? Do you have the medication? These are all kind of outcome measures that we're looking at ultimately. So what are some of the drivers, at least domestically, that you are seeing, the big ones?
So I mean, one of the biggest ones is race. So just the way that race is so strongly bound up in kind of everything in this country, in most countries, let's be real, kind of patterns your access to healthcare, to education, to income, to the quality of the care that you get, you know, even to how close you are to be able to access quality, affordable care. So I would say that kind of shoots up at the first. And again, you know, just, you know, education is another one. And residential segregation is actually often a really important driver that we don't talk enough about. But right, people are not randomly distributed in this country. It's very much the result of long and very intentional actions on part of, you know, on part of our own government, you know, historically. And that has had long-term consequences for the ability of people to live kind of healthful lives. And we see that play out in HIV no differently than other things.
And Katie, back to you. In Africa, there's different social, I mean, there's similar categories of social determinants of health, but there's different resourcing type issues. So what were some of the things that you experienced?
Yeah, I mean, there definitely is a lot of overlap. You know, we talk about the economy and having a job. I think one of the biggest barriers that at least we've seen among our patients in South Sudan is lack of finances to pay for transportation to get to the hospital to pick up their refills, right? And so I think that there are a lot of similarities, but it's also, if you look at the global pandemic, I was happy that someone put gender up there, because the way that the HIV epidemic looks in the United States is very different from where it looks elsewhere. So some of you might be familiar with key populations, right? So men who have sex with men, injecting drug users, sex workers, and transgender people. And if you look at within sub-Saharan Africa, the proportion of new infections that can be attributed to those key populations, it's much lower compared to everywhere else outside of sub-Saharan Africa. I do have the numbers here. Yeah, so key populations account for 39% of
It wasn't a workers' comp situation. You don't have a.
Yeah.
Thank you. But then 95% of the new infections outside of sub-Saharan Africa. And so if you're looking at prioritization, in that recent report that UNAIDS just came out with, talking about this is the progress that we've made, this is what we've been able to achieve so far. Gender equity and gender equality is a key component of the strategic direction moving forward in order to make more improvements. So yeah, definitely gender.
Rashard, I want to go to you because I'm from North Carolina. I'm from Eastern North Carolina. When I came out of the closet, although people said it was a glass door in medical school, when I came out in Greenville, it was not an easy thing. It was in 2000. So last year was my 20th, well, 2 years ago, COVID has blurred everything. 2 years ago was almost my 20th anniversary. It took a long time for me to get to the point to be able to talk with my family. But I know in some communities it's even harder. You're in Eastern North Carolina, or you grew up in Durham, correct?
Correct.
So not quite Eastern North Carolina, but tell me about some of the stigma and how that has been very difficult for patients. And that is also a determinant of whether or not people seek treatment. People know to ask, people get tested, et cetera.
So stigma plays a really large part in individuals not only getting care, but getting tested. number one. The stigma that's associated with going to a local nonprofit to get tested can kind of hinder someone from even going to get tested just because it is assumed by, outside people that because someone has gone to go get tested, unfortunately, they assume, oh, you must be HIV positive if you're going to this particular location for any of the services that they might offer, when in reality, they're just taking the appropriate steps to own their sexual health and to own their actual own well-being. Speaking of Eastern North Carolina, I have done a couple of programs down there just to kind of do some testing events. And that really opened my eyes, especially coming from Durham, going to the eastern, more rural parts of North Carolina, to how that stigma is placed, not only from the outside, but even the people that work in the field. So at one of the events that we did, we had one of the testers to come up and kind of speak to the audience before we got started with the testing. And so when she came up and she started talking, it was a moment of shock, and we were trying to figure out, we were scrambling, trying to figure out what to do. So when she stood up in front of everyone and she was trying to encourage people to get tested, she began to tell this story of her niece. And she says, well, hey, everyone should get tested because my niece went and got tested for the AIDS, and she found out that she was positive, and 2 weeks later she died. So everyone should go get tested. And it was that moment to where we're trying to encourage people to get tested, but it was that moment of knowing that even whenever you do go get tested, that educational piece from someone who does the pre-counseling as well as the post-counseling once you get your results, is kind of adding that fear aspect, which is a part of that stigma, because even in 2021, some people think that it is a death sentence, when in reality, as Adam pointed out earlier, it's really just a manageable disease. So that stigma plays that huge part in that, as well as I've ran into clients who the stigma also stops someone from disclosing to people who are close to them. And one of the things that someone who's living with HIV needs is a strong support system. So when I had a patient one time who somehow some information he left out in the house, and his daughter kind of went through some mail and saw some information and saw his status. So although his grandchildren would come every day and spend time with him every day, once the daughter found out his status, she no longer allowed the grandchildren to go over to the house. Because it's a matter of that stigma comes in, as well as that miseducation, to where, again, people don't really know where and how they should do, which is why I kind of started Breaking HIV Stigma, just because we try to ensure that the marginalized communities, that we are trying to get them the resources and education to kind of break that and to try to normalize the conversation around, not only around HIV, but sexual health in general. Because I have witnessed where patients will go in and speak with their doctor, but they aren't honest about what's going on, or they won't even tell some of their providers that they are HIV positive. So it's not just a matter of the stigma from the standpoint of just someone that they know or a family member, but it's even stopping someone from telling that to their healthcare provider when they need to kind of disclose that information so that they can get the proper care that they need. But it's one of those, you never know how someone is going to react. Is it going to come off judgmental or anything like that? And so here in North Carolina, you see that, especially in our marginalized communities. So the North Carolina Department of Health and Human Services just released their annual report for the HIV surveillance. And in 2020, I want to make sure that I quote these numbers correctly. we have to take into account COVID really shut things down, limited the access to even getting tested. But in 2020, there were 1,079 new cases of HIV diagnoses. Of that number, about 57.8% of the newly diagnosed cases were among African Americans, opposed to approximately 24% of white or Caucasian and 13.3% of Latinx or Hispanic. So you can really see how that plays a part. And so within the African American community, or any community, it's already taboo to talk about HIV or your sexual health. But then you add in the other factors of the mistrust with care providers. When you start to add in the social determinants of housing, if you don't have anywhere to stay, I don't expect it's hard for a patient to, continue on their medication. And one of the big things that I noticed when COVID hit is that the lack of knowledge of resources really came to the forefront, because people weren't aware of the programs that are available to them. So a lot of people, when they're diagnosed with HIV, it's already a hard system to navigate. But they aren't aware of like the Ryan White programs that can assist with low-income individuals obtaining their medication free of charge, or getting that assistance to cover their visits to the doctor. So those parts are kind of taken off of their plate.
So you mentioned something about knowing resources. So kind of a funny story. I told you I came out in 2001, first year of medical school. I didn't get tested for HIV until my first year in residency. And I was sitting down with one of my attendings, Ted Corbin, and he said, "Oh, you need to go get tested." And I'm like, okay, where do I go? How do I get there? What happens? And I will never forget this to this day. He, obviously because I'm telling you about it now, but he grabbed me, he goes, "We're going." And so he went with me to the clinic. It was the Blacks Educating Blacks Against Sexual Health, or for Sexual Health. I walked in. I didn't know I could go to this clinic because I'm not Black, but I could. I went, and the person sitting across from me, she was so extraordinarily kind. She normalized it. We're like, yeah, this is just what we're going to do. We're going to do this, 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 and I'm like, whoa, you're getting a little aggressive. I came for an HIV test. I come for all the other stuff, but sure, okay. Now, back in the day, you had to wait about a week. And so you had like a week or so of just sheer panic of what was going to happen with your life. And now you don't have to do that. But then he went back with me to go get my results. They would not call you to give your results at the time. You had to come back in, which even was more panic. Here's the point of that story. I was terrified. Being a kid from Eastern North Carolina that grew up in a Southern Baptist home, you didn't talk about sex, you did not talk about HIV, you didn't acknowledge that I spontaneously combusted and ended up in my family's house. That's how I got here, So like, we don't have any of those conversations. You certainly don't have conversations about being gay, or you didn't. And just so you know, my husband came home with me to Thanksgiving and everything's good now. So it's a good happy ending. But point here is he helped me navigate that process. And that is how I got comfortable with getting tested. But that doesn't happen everywhere. That navigation process doesn't happen. That's number one. Number two, you mentioned something I think is really important to draw out, is the hierarchy of needs. So I was in Haiti a few years ago, and one of the persons that was with our group, and I had planned to go down there a lot, but COVID and civil unrest and all the things happened. But anyway, she says, "Why don't they pick up their trash?" And I was like, they don't have any food to eat. Trash is the last thing of their worries, like there was not a concept of the hierarchy of needs. Food, shelter, like beautification projects were not on the order of priorities. And so when it comes to taking care of your own personal health, it always falls to, I see it with every patient population, it falls to the back burner. Why? Because if you can't pay for your food, if you don't have housing security, if your job is threatened, if you've got bad situations going on with your family, those things always come secondary. So it's really important that these conversations start happening. Yeah, Derek, I want to go back over to you. We have this new magic pill, right? Called PrEP. It really is kind of magic. I mean, honestly, it's a really kind of an amazing thing. But there's still hesitancy with that. There's difficulty with getting it. What are some of the reasons? What are you seeing and what can we do about it?
Yeah, so just for folks who maybe aren't aware, right, PrEP is basically an old kind of HIV medication that has been available for HIV prevention for 10 years now, right? So you take this once a day, and it basically kind of almost nullifies your kind of risk of HIV infection. So that's why I think it's basically magic, right? It has proved that we kind of have, this really powerful biomedical tool, right, to end the epidemic along with, right, kind of U equals U, right? We have kind of what we need. In the kind of worst version of I told you so ever, when I was a graduate student, a colleague of mine wrote this paper. The minute it came out, we were like, this is exciting, but it's not going to be the game changer for inequities that people think it is, because we haven't thought through how to get this in the hands of people who need it. And sure enough, yeah, it was right. Right. But, I'm so happy that as many people are accessing it as they are, which is great. But again, if PrEP is going to meet its potential and really kind of ending the epidemic, it has to be in the hands of the people who need it the most, right? Those who are kind of most likely to become HIV infected. And so, at least in the United States, right, that's going to mean kind of men who have sex with men of color. And unfortunately, we've just seen this huge lag, not only even in just kind of knowledge of PrEP, but kind of where to get it. Do you have, insurance that, will cover it? And thankfully, a lot of those barriers are starting to fall away.
If you have insurance.
If you have insurance, yes. That's always a big one in this country, right? And so that's obviously important, and like Richard was saying, there's now thankfully some programs that can even, assist you with getting PrEP, but you have to know about those. And another big barrier is do you even have access, I'm not even just talking access to healthcare, do you have access to kind of a physician who knows enough about PrEP to prescribe it to you? Exactly. I have a friend who, he lives out in Western North Carolina. And that was an issue when he first moved out there. He's like, yeah, I know what PrEP is. I want it. And he's like, well, my doctor won't give it to me because, it wasn't even an antagonistic thing. It was just I don't know. I haven't prescribed this before. I don't feel comfortable doing this. And so there needs to be a lot of kind of normalization and education on the healthcare provider side too, right? Shouldn't require that everyone, everyone doesn't need access to a specialized infectious disease physician. There's just not enough of them, right, to go around. So, we have to think through a little bit better in the service delivery aspect too, of how we're going to do that if we want to really get PrEP in the hands of folks who need it the most.
Yeah, primary care is one of the biggest prescribers of psychiatric medications, right? They can be one of the biggest prescribers of PrEP as well. It doesn't take any 3 or 4 years of extra residency programming to learn how to get on top of the guidelines. Katie, I want to finish kind of the PrEP, or not PrEP questions, but the questions that I asked to you, and especially from a business perspective. I thought something you brought up yesterday was extremely important. And it was the discussion around equity of stakeholders at the table when decisions are being made. And I think that's applicable to everyone here. Can you speak to that?
Absolutely, yeah. So I've chatted about these targets, right? We're very focused on targets, trying to figure out our progress. Now, some of you might be familiar with PEPFAR. That's the President's Emergency Plan for HIV/AIDS relief. That's all of the US government funding that goes towards global HIV/AIDS relief. And PEPFAR, I've worked on PEPFAR funded projects since my career started. So I am very familiar with all of the requirements as an implementing partner on what we're supposed to report on. This is all of the progress that we've made. And really, this is partially what drove me back to come back to school and get a PhD, is that working for these implementing partner organizations, US-based NGOs, right now I'm with RTI International, we are receiving pressure from the PEPFAR funder. So it's divvied up between USAID, CDC, and the Department of Defense. So I work with military populations. So the PEPFAR funding gets funneled through the Department of Defense HIV/AIDS prevention program. And so PEPFAR is telling DOD, USAID, and CDC, like, we need to meet these targets or we're gonna pull your funding. And so DOD's like, oh no, we need a bigger piece of the pie than CDC and USAID. Like, we need to reach our targets. And then they then come to us as implementing partners and they're like, you need to achieve your targets. And if we're not close during that one quarter, or like don't get 25% during a quarter, they're like, you're gonna lose your funding. You need to achieve the targets. And historically, the implementing partners then apply that pressure to the key stakeholders in country. And they're like, look, like, we're here to help, but unless we achieve these targets, then we're not going to be able to like continue supporting you, to continue helping out. And the implementing partners sitting there and saying like, I told you, like, what am I supposed to do if we don't have staff because they haven't been paid, or like they don't have enough money to get to the hospital in order to provide services to our patient population? Like, what am I supposed to do? What are you talking about? Like, targets for like the total number of people tested within the community? Like, hello. And you were talking about prioritization, right? Like, really, is this our biggest priority? And if yeah, so there's this, as an implementing partner, I've kind of seen just this discordance between what is prioritized by the donor and what's prioritized by the local stakeholder. And historically, these local stakeholders, the beneficiaries, whatever you want to call them, aren't sitting at the table when those targets are being identified. So there's definitely been a number of times where we share, we're like, hey, these are our targets for fiscal year 22. And they're just like, are you serious? Like, why did you increase this? Like, we obviously didn't reach it last year. And it's just this, yeah, there's, people call it the like PEPFAR white tower, like folks that are just so far disconnected, identifying what our target should be. And, you know, you were talking about power, right? And so if we're thinking about this system and who holds the purse strings and who has the power and who's identifying what the priorities should be, like, the system's broken, right? So if we're talking about equity from a systems level, it's just so important to like really take a step back and think like, okay, why are we here, right? Like, obviously we want to end HIV. On the one hand, like, keeping track of these targets is really important, right? Like, as a researcher, yes, love data. Data is great. But on the other hand, it's like, okay, we're here to support and help. And if the way that it's like trickling down, like what those priorities are, like, that's a huge issue. And so I think, you know, if we're trying to identify recommendations, I'm assuming a lot of you are students, potentially business school, not sure what fields you're looking to get into, but I really encourage all of you in whatever position that you end up being in to like really reflect on whatever those power structures are in the system that you're working in, and identify, like, as an individual, what can I do? And I've personally found it really powerful, a really powerful reminder to like get to know the people that you're working with, right? Like, learn from their experiences, especially in global health. Like, some cultures, it takes a really long time to establish that trust before someone will speak openly with you about like, oh yeah, by the way, here's this problem that's been happening for 6 months that I'm only telling you about now. And you're like, I wish you told me so I can help out, right? But like, by establishing those relationships, by getting to know people, like, it's a really helpful reminder of like, why am I here, right? And I think that that's something that we can all do in all of our positions, regardless of where we're working. And especially if you are in a position of leadership and you do have the power to affect organizational change, to either at an organizational level or at a systems level, prevent this from this power imbalance that's just been hamstringing us, like, you know, forever.
It happens in every organization.
Yeah.
The quickest way for something not to get implemented is not to get the right stakeholders around the table, not to have
Right.
open conversations. And that's in healthcare, that's in multiple reorgs like we've gone through. I mean, it's something that, take that message home, it's important. Well, I wanted to open up for questions. It's a little wonky to try to do it via Menti poll, but I just wanted to open up the questions because we got great thought leadership here. So, questions? We got about 5-7 minutes.
So obviously, I'd be very curious to hear kind of your perspectives. I think with COVID, obviously, it's a pandemic that people actually are paying attention to. Obviously, HIV/AIDS kind of hit its peak. People weren't paying attention, and I was on social media last night and I actually saw this very interesting thing I'd never seen before, but it was actually like this of people wearing masks. And basically in like the 1990s, apparently to prevent HIV from catching HIV, obviously, which is not how you get it. So I'd be curious just to hear kind of your perspectives, kind of seeing how COVID's unfolded.
I like you haven't talked about this, but I will be brief. In short, I think we have to be careful with the comparisons. I think there are some useful comparisons. I just think we often knee jerk to making like the wrong ones. In some ways, the kind of least useful comparison is the fact that they're kind of both infectious diseases, right? I think the most useful comparisons is how did our society kind of respond, right? And I think what is troubling is how little we seem to have learned. And so like, I remember, you learn about this history of HIV and you're like, what do you mean the government didn't take science into account and perpetuated stigma against the most vulnerable?
For 2 decades.
And so I think you've seen a lot of, it's just, again, it's like tragic how kind of easily predictable I think a lot of this was. I think things are a little different, of course, right? I think, and Adam's talking about information, misinformation and disinformation, and kind of that has played, I think, even more pronounced role now with COVID. But I think those are the kind of interesting comparisons and lessons to draw, is less about COVID and HIV and more about what have we as kind of beings who live in a society that shapes our health done differently, and why has not that much changed. I think that's the answer we have to, I think, come to terms with.
There's an opposite kind of way I like to look at it. I too don't love to make comparisons with COVID, the COVID cluster with HIV. But I do think that there is something aspirationally we can look at COVID for HIV, and that is this. It's so common to get tested for COVID. It's no big deal. You just go wherever you go, you get your test. It's common for people around the house to talk about. I mean, I was just at Thanksgiving. Y'all see her? She had COVID, blah, blah, blah. I mean, it's just like, it was not a big deal to have a conversation. That's aspirationally where I think it could go, because that's when conversations happen and it makes people comfortable with getting tested.
Thank you for sharing your experiences. One of the very interesting points that came up was hierarchy of needs. So how do you think, or where exactly do you think HIV/AIDS stands across all the other disease areas that are currently burdening our world, especially from a point of view, I come from India, and I know that the HIV drug is probably the cheapest right now in India. When I was back in doing my pharmacy rotation, I was in the rural areas for a while, and I know for a fact that people did not show up for even basic vaccinations, let alone HIV drugs, or being needful about that. So how do you think government or the authorities or whoever is working towards this should work on framing the need or the gravity of where HIV stands in comparison with other diseases, like especially COVID? I know India struggled with, people in India struggle with getting the vaccinations. Do you think people would focus more on HIV right now, given that other disease areas are kind of more in the light? Because
I mean, short answer, no. Everyone had to drop everything once COVID hit. I was speaking with someone in the health policy department that helped with the COVID response in Seattle. First case, what do we do? And it is heavily politicized, right? And so I think from a public health perspective, we can identify our priority list, and we all have the things that we care most about, maternal, infant, child health, family planning, violence prevention, HIV. If you look at like the overall burden compared to say chronic disease, like it's not as high, right? And so like, I think it's very political. Whoever is in office is going to be the one to make the decision on where to prioritize those investments. And yeah, like unfortunately, like with COVID happening, like I am a little bit concerned in terms of global HIV response, but like limited resources, limited time, we can't do every single possible thing at once. I'm not sure if that's the answer. you're
Well,
looking
two
for.
things, I think it's absolutely right. Two things there. On a micro level, patients to have delayed significant amounts of care due to COVID. That's HIV patients, that's heart disease patients, hospitalizations in non-COVID related patients dropped over 20+%, I think it was, by the end of 2020, even though there was a rebound. So we know to what you were saying, there is a shift that occurs. But when I'm talking about hierarchy of needs, I'm talking more so of you have to direct resources to communities and to people that have major structural deficits in the things that make them tick as a human. Educational deficits, housing deficits, access to healthcare. Those things have to happen. And here's the good news. It helps in a lot of other diseases, not just HIV. The third piece is you can, as clinicians and as a healthcare system, walk and chew lots of flavors of gum at the same time. That's why we have, like at UNC, we have multiple departments. And so the hierarchy of need for an individual is when they have a crushing disease that's causing a significant burden on their life, then that's the most important thing. But as a healthcare system, we can take care of a lot of people and a lot of things at one time. And so my point here is that it's layered and it's political, but it's also can be focused and targeted in our response.
I'm curious about, you talked about like limited resources and especially like in sub-Saharan Africa. Is there a focus on prevention? Like how accessible is PrEP there? Because you talked about kind of like the testing and then making sure that people are getting medicated, but what about on the prevention side in sub-Saharan Africa?
Yeah, absolutely. Yes, there are lots of programs that are focused on prevention and testing. PrEP is available, at least it's one of those targets, one of those PEPFAR targets is the proportion or total number of people that are on PrEP that are being served by the facility. I think at least in South Sudan, we didn't receive that as an indicator until this fiscal year. So whereas I do have some colleagues that work in other countries in sub-Saharan Africa, and that has been one of the targets that they need to report on for many, many years. And I think that has to do with, if there is a country that's struggling to meet targets as they exist currently, like if you keep adding more and more responsibilities, like now you also need to start distributing PrEP. It's a lot to juggle, so. Yeah.
So we're at time. Do you think one more question?
Yeah, because we're out of the room by 2, we're good.
Okay.
So 30 more minutes.
Another question.
Yeah, so I really feel, and I heard about this from another panel, that like HIV is a zip code disease. It really is, right? And so how are healthcare systems, like payers and whatnot, how are they using this data, this great data that we know of, right? Because it is a zip code disease. You can probably, really hone in on like the neighborhoods, the areas of, Atlanta, whatever. What are they doing to educate these patients on PrEP, on like treatment options and whatnot? Because like they're doing this with diabetes, they're doing this with chronic heart failure, they're doing this with hypertension. So like, what are they like? How are we going to change the minds of the payers? Like this is just a disease that's treatable that people live with like every day. Like how do we do that? How do we change these minds? I mean, is it just infrastructure? I mean, because we talked about it yesterday. I mean, North Carolina has a long way to go with the infrastructure of even just primary care, just getting that, because there aren't, internet lines in rural Carolina, North Carolina. So like, I mean, it can be a little political as well, but like, how can we incorporate all these entities together to really improve like the value of care that we're getting?
So having negotiated with payers. So, you know, there's really two things to consider with what payers are going to focus on. One is in many cases, payers, now there's non-governmental and governmental payers, right? So Medicare, Medicaid, governmental, non-governmental, like PCBS and United Healthcare. Those, what you do need to show them is how you improve outcomes by reducing cost. And so if there's a significant amount of disease burden in a population, then if you can show that whatever you have done from an innovative standpoint reduces costs, you can improve and you can improve outcomes. That's really what speaks to folks. So, but the key is improved outcomes reduce costs. So I would say that you made a couple of comments about like hypertension, diabetes, other things where there's navigator programs and these type, you can call them navigator programs, but programs out there to kind of help people along. They're not widely done. They're not widely used to the point that it's making huge, big differences. And so there's opportunity there, folks. Huge opportunity for those in the healthcare. And that's where there's a lot of opportunity to start looking at value-based care, accountable care organizations, ideas around that. And HIV plays into that as well, because when those patients get truly, like really, really ill as their viral loads go up, and some do get develop AIDS, the cost to the healthcare system is huge, and especially when there's other diseases as well. So that's really the key, is showing the improvement of outcomes with an intervention, and that's how you, with small pilots, that's how you start to get insurance companies to pay attention, and then make bigger structural change.
I guess I'll just jump on that, so I definitely don't kind of exist in the kind of business side of healthcare, but I think, it's so important that we kind of forge those partnerships, but I also think we have to fundamentally rethink, like we have to think, how do we also intervene outside of those systems, right? Because they will, by definition, never meet kind of the needs we need, right? So for example, like a lot of you might be really shocked to learn that in the United States, if you're a Black gay man, you have a 50% lifetime risk of becoming HIV positive. 50 in the United States, okay? So, I think for a lot of us, it's like the burden has been there, right? And so it's like, okay, well, if the market forces aren't kind of necessarily driving it, what do we need to do to really encourage, other actors to kind of really invest more critically in communities, right? I think another example of, the opioid epidemic has been a problem in many communities for decades, right? And I'm not mad that we're like investing resources into it now, but like, again, it does speak to, I think there is we have to really, really kind of come at this from so many different angles, because if we don't, it's always the communities that kind of need these resources the most that kind of get left behind first.
Can I just play off of that? So I can't remember what year it was, but the government made a decision to fund dialysis. If you got kidney disease and you were put on dialysis, they funded it. And guess what? There's now focus on dialysis centers. Now, I'm not saying that's the right answer, because there's issues with the dialysis centers and all that kind of stuff. But the point is that there was funding outside of, there was focus on a specific disease outside of the normal market forces. And I think it's a phenomenal point. Last question.
Like due to like obviously the COVID outbreak, like we advanced really far with the mRNA like vaccines. I wanted to know if you like see a lot of promise in that and getting towards an HIV vaccine that can maybe you take it once a year or so to prevent HIV.
That's currently being tested. That recently, I want to say I read a report last month. There was current testing. Everything's kind of blurring. Maybe it was in the last 2 months, but that is currently under. They're looking into it. The other thing that has happened more recently with HIV treatment has been the long-term injections, and so whether the injections are in a 2-month or a 1-month type of dosage, so that there's not an everyday prep. We see that same type of thing happen with psychiatry. So for Haldol. For patients who have schizophrenia, that they go once every 3 weeks for the Haldol definitely shot. Kind of a similar type of thought. It's really hard from a compliance standpoint for someone to remember to take medications every day or to get them. And so if there's a way to give it in a shot like that. So they're doing that in the UK and also here in the United States. All right, well, listen, I really appreciate your attendance today. I really appreciate these folks. It's been fun getting to know you guys. I'm gonna continue to ask you questions, so you're not done with me. Linda, Aaron, I really appreciate it, from the Healthcare Club, the Pride Club. I'm gonna stay over for a bit to talk about Omicron, Delta, where we are, what's going on. So feel free. I've got a couple slides I'm going to pull up just to kind of show some things, but feel free to stay. Feel free to ask some questions while I'm pulling that up.
Better get your vaccine. Like I think Black Twitter is a huge wonderful world.
Or Omicron, depending on how you want to pronounce it. Would you like me to talk about it? She's like, sure. So let's talk about a couple things first. So we are currently here in the United States in the midst of the Delta wave, right? So what is the Delta wave? So when COVID came, COVID 1.0 came around last year to 2020 and was started in 2019. When the disease came out, we were all shocked when it showed that for every one person that got the disease, 2 would get it, would be transmitted to people. Because that was on the order of like worse than a really bad flu year. And so when we as clinicians start to think about viruses and about viral spread, we start to think about how many people could get it if one person gets it. Then we start to think about how severe would the disease be in the person who does contract the disease. And then the third is then what are going to be the treatment or therapeutics available for it. And of course, at the time, we didn't have any of that at the beginning of 2020. And so with the original form of the virus, we saw for every one person to get it, 2 would end up getting the disease. Now, of course, there are super spreader events that you hear about, meaning like one person, the president of the United States goes to like a big event and like spreads it to a whole bunch of people. That of course means that one person can spread it to a ton of people, but in general, on average, it was 1 to 2. Well, over time, viruses that are spread in an unmitigated fashion cause mutations. HIV causes a lot of mutations as it spreads. The more that it spreads, the more transmission, the more likelihood that it picks up little pieces of genetic material it incorporates into the virus, and then it becomes a new variant. And then the question becomes, does the variant become a dominant strain or does it die away? We've already had multiple strains of COVID that have been there's been outcompeted, is that the word? Against whatever the dominant strain was, until beta came along, until alpha came along. Alpha, which was fairly big here towards the end of 2020 into early 2021, and beta, those were 2 big dominant strains. And then all of a sudden, we all thought life was normal. I was dancing in a club in July. It was fun. Lights were blasting. Fog was going on. It was great. July like 5th or 6th. And then I got COVID like 3 weeks later, not because of that event, but because you guys heard about the Provincetown thing, right, that took place. I'd gotten vaccinated in December and then followed up in January. And then a lot of people were coming back from DC, friends of mine who were in Provincetown, who's like, Adam, I just tested positive for COVID. I'm double vaccinated. What now? And then 2 or 3 days later, same thing happens. So what happened there? That was really kind of the start of the Delta variant. It started really overseas, of course. It's kind of going throughout Europe and then made its way over here. But a couple of things were happening to allow the Delta variant to really grow. One, it mutated and it outcompete the other mutations or the other variants that were out there. But the other is, for so many people who got vaccinated, we know this is not just with this vaccine, this is all the vaccines. Over time, antibodies start to wane. That's a reason why we get tetanus boosters. That's a reason why we get hepatitis B boosters. You know, those start to wane. And so it was really this kind of convergence of events of a decline in antibodies with a stronger variant that allowed Delta to come back into the United States. Now here's the deal. Remember that 1 to 2 thing I told you about? Delta was a 1 to 5. So it was a huge, huge bump in the transmissibility of the virus. Now, at that time, we had a couple of good things. We had a vaccine, right? And so what we were able to show, or what was being shown, was that while the vaccine initially was preventing disease 95% of the time, unless you had the J&J vaccine, but 95% of the time, all of a sudden, as antibodies started to wane, hospitalizations didn't increase, but breakthrough infections started to go up. Now, fast forward to August and September, the big debate of the boosters, the big debate of vaccine equity, all happening. Should we get boosters? Should we not get boosters? What does the evidence show? When we started getting information out of Israel, started getting information out of the UK showing that as the virus, as the Delta variant was spread and as it had more penetration in the community and more people were exposed, even vaccinated individuals were exposed, as their antibodies waned, they too were getting infected. So remember the thing I talked about unmitigated spread as a way to increase variance? So now your vaccinated people are spreading it, albeit at a less rate, because not as many of them are getting sick. And then your unvaccinated people are spreading it. And so that is the potential for another variant to take hold and enters in Omicron. So if you now, what we know is it is basically in over 20 some countries. It is now in California, Minnesota, and New York. you've been following Twitter this morning. It has been here. It has been here for a while. I feel really horrible for South Africa because they need the Platinum Star for actually having a surveillance system and a tracking system, for raising the red flag and saying, hey, we've got a variant of concern. No need to panic. And what does the rest of the world do? Lock down South Africa when it was probably in the midst of all of those countries. And we now know that it was in Europe, it was in the United States, most likely well before that, showing that there is even community spread. What do I mean by that? Community spread means that you can't point it back to a singular source in kind of the country of origin or the place of origin where we thought that it started. That means that it's spreading amongst the people already and it's within the community. So here's the thing that we know about Omicron, and I wish I could show you this graph, and this is why there is concern now. If you take a look at a graph of the rate of rise of Delta infections in South Africa, and you compare it to the rate of rise of infections with Omicron, there's a significant increase in the slope of rise of the number of infections, the speed at which it's transmitted with the Omicron variant versus Delta. And remember, Delta was a 1 to 5, a very scary transmissible disease in an unvaccinated population. So the worry now is, now you have Omicron, which looks like it will outcompete, most likely Delta. In many of these countries, it appears in South Africa, for example, 2/3 of the samples of blood samples that they took on patients that had, or on viral samples that they took, 2/3 were now the Omicron variant. So it's now the dominant strain there. It outcompete Delta. That means it outcompete people that were vaccinated. Only 24% of people in South Africa were fully vaccinated, but also outcompete people that were, of course, had been infected before. So now, if you take a look at England and Scotland's numbers of their rapid rise of infections over the past couple of last week, you will also see a spike of cases that have been coming through. They haven't sequenced those yet, but I have a suspicion that many of those cases are likely Omicron cases because Delta started to slowly wane in those countries. So here's the deal. What do we still need to know? Well, it looks like this variant is more transmissible. That's a very concerning thing, right? Because Delta was super transmissible. We probably need to move across to KN95 and N95 masks. Surgical masks are probably not going to be enough to protect us. Secondly, will it hold up against the vaccine? Now, Pfizer CEO said, yes, it will hold up against the vaccine, but we're going to have to watch it. Moderna CEO said, I can't see that it will hold up at the same rate as the vaccine that we currently have. It'll need a 2.0. And the answer is probably somewhere in the middle. And hence, this is the reason for boosters. The reason why boosters, and I encourage all of you to get boosted. The reason why there's importance to get boosted right now. Whenever you get boosted with a vaccine, you get this really huge rise in antibodies and neutralizing antibodies within the body. But you also get a secondary immune response that occurs within the body as well. And so that double-pronged immune response really supercharges the body to protect it, not only from the very specific virus that is trying to attack you, the variant, but there may be some pour over and spillover effect of protecting other viruses. That's why we think, every year we go and we get our flu vaccine. Every year the flu vaccine is usually a combination of a couple of different strains of flu. Not every year is it really bad. There's probably some memory immunity in our bodies from the multiple vaccines that we've had, even though we may not have the specific antibody, even if we got vaccinated and we got sick. And so the hope is that if we all are getting boosted and we have really high levels of neutralizing antibodies, that if Omicron does come, and it will, but when it does come in the next 6 to 8 weeks and really starts to peak, what will happen is if the people are boosted, it'll really reduce the chances of severe illness. Now, last night when I was on CBS last night, when I was on the news last night, I was asked this question, well, why do we need to do this boosters for, when we don't even know it'll work against Omicron? And my answer has been the same when I've been asked this twice this past week. 99% of the cases in the United States currently are Delta. And we know that after 6 months, your antibodies wane significantly. We know that there are portions of the populations with underlying immune conditions that even after having 2 doses, that there's significant issues with their immune system mounting a solid response against Delta. We also know that the more people that are sick, whether you've had the vaccine or not, more dangerous it is for the unvaccinated. So this is a reason why we still need to get people boosted right now. Anyone over the age of 18, anyone that's over 6 months. Actually, in the UK, they're recommending 4 months. So after 4 months of an mRNA vaccine. Now, will there be a 2.0 version of a vaccine? Possibly. So if we learn from scientists that that this virus does in fact evade the immune system, the Omicron variant, then I think Pfizer said that it'll take about 100 days for them to sequence and produce another mRNA and do testing. Now, how long will it take to determine safety profiles on that? I don't know. How long will it take for regulatory agencies to be comfortable to say, yep, we're okay with the 2.0? The bigger question that I have is how long will it take logistically to get that vaccine to parts of the world? Because right now we're doing an okay job in the United States. I mean, 72% of adults are vaccinated, but 41% of the United States are not vaccinated. There's parts and countries, the poorer the country, the less likely there is to be vaccinated. And that's billions of people. More than 3 billion people are under vaccinated. So, didn't have my slides, but that's what I want to tell you. So buckle up, buttercups. It's not going to be a fun winter, unfortunately. A lot of times we're going to have to watch and see what happens. But the big 3 questions: transmissibility, severity of illness, and does it evade the vaccine? Those are the things that we need to be watching for on how much of a disruption this will be. And then second thing we need to watch, other than those 3 questions, is Delta's not done with us yet. My friends and colleagues in Michigan right now, they are getting their butts handed to them. They've had the highest record number of COVID cases ever during this pandemic. We're going to start seeing that in pockets, especially in areas with high levels of unvaccinated patients or unvaccinated people. Michigan is sitting very close to the national average. Guess who else is sitting close to the national average? North Carolina. So we need to watch this space very closely, continue to protect yourselves. The pandemic, sadly, is not over. And, I wish you all well. So, questions?
I'm sorry, when you said the 6 to 8 weeks, was that until you think it's like across the country?
Yeah, if you look at, so what we know now out of South Africa is that it does compete with Delta and now competes it, okay? We are seeing that, some evidence of that in England. And so that doesn't mean that we'll start to see 1 or 2 cases here and there. I think over the next couple of weeks, we're gonna see onesies and twosies. Oh, we got, just like at the beginning of the pandemic. But I think for there to be truly a wave and we start to hear, Houston, we have a problem, that'll probably take, depending on how quickly it's transited, 6 to 8 weeks. Yes.
May I ask, and this is kind of coming from the whole, I'm a grandparent now, so I've got this little 3+month-old grandbaby. My daughter had took her vaccine during pregnancy. She's going to get the booster. I've got my booster, but I'm super concerned, like, because this is a little baby who cannot get that. What are the precautions? Should I, with Omicron now, should I stay away? Should I wear a better mask? Like, what are the protections there? Because that's
a
serious.
phenomenal question. So number one, we have seen as these variants have come out, a skewing of younger and younger. That should not make you feel better. But what should make you feel better is that even though we do see some children, meaning like infants and under 1 year of age, getting it, it's a very, very, very small number. Okay, so that's number one. Number two, you said 3 months old?
Yeah.
He or she should have some antibodies from the mom, which is also kind of a cool thing about immunity and also pregnancy. Okay, so that's number two. Number three thing is I still would consider a lot of the public health measures of keeping your circle small, keeping the number of people of interactions relatively small. If you are having more people around in the house for the holidays, making sure that it's as well ventilated as possible. But think about it from a statistical perspective. If you are boosted, there's a 95 to 96% chance that you will not get infected. which means you'll not spread the disease. If your daughter is boosted, there's a 95-96% chance. If you guys are the only people that are really interacting, or the 5 or 10 people that you're interacting with, the chances are dropping more and more and more and more for there to be an exposure risk to your grandchild. And so the message that I've been giving people is do all the normal, wear the masks, limit your contacts, avoid large gatherings. But if you are having gatherings, I mean, it doesn't sound as fun, but you got to make sure people are vaccinated. And that's really the number one thing that you can do to protect your kiddo, your grandkiddo.
Yeah, great.
Congratulations.
Great, thank you.
So I don't come from a medical background at all, so I was wondering, when we heard a lot about the Delta variant, it was like a lot of times when, at least what they're saying through the news, is that these mutations, a lot of times what happens is they mutate so they can continue to survive, right? So obviously it could be more transmissible, but usually there will be maybe like less effects, right? But that wasn't the case with the Delta variant, and it seems like maybe that's not the case with this next variant as well. So I was just wondering what is changing that is making these variants now both more transmissible as well as potentially affecting people in a more negative way.
Yeah, so I wish I brought my little prop. So my dog has this squeaky toy that has all these spikes all around it. That is what I've used to demonstrate the coronavirus because it's kind of perfect. It kind of looks like it. But those little spikes on the outside are really like hooks. Some of the hooks are sharp and some of the hooks are not so sharp. And so, for example, in the original form of the virus, it was a relatively good hook. But do you fish? Okay, or like a singular fishing hook or a 3-prong fishing hook, okay? Delta's like the 3-prong, right? So like it gets into the body, it hooks into the body in a mucosal membranes in a much stronger fashion and tends to coalesce more so in the upper airways versus the lower portion. Why is that important? So when you're talking, you're speaking, you're coughing, there's more viral particles there to release out. So not only does it get into the body easier, it's where it lives within the body is easier for transmission. So that's the move from COVID-1 to Delta, right? Now with Omicron, what we do know is that there's been more than 50 mutations, 30 in that hook. And it appears that that hook, that spike protein increases transmission. So it tells me that it's probably improving the way that it enters into the body, like it gets encapsulated into the cell much, much more easily, but also probably living in the upper airways in a higher number so it can be more easily transmitted. Now, here's the big question though, is does that also mean that it's going to make a person more severe? Let me tell you, when I was on my pediatric rotations, I was sick every damn day because those kids are little booger snots. They are like spreading, sneezing, coughing, and it's like they've got power viruses. But I didn't get that sick. I mean, I just felt that awful. And so is this like a little 3-year-old with RSV that has the seasonal RSV that's very easily transmitted, where an adult doesn't get that sick? Or is it something more severe where people are getting as sick as they are? Yes, I was sick the entire pediatric rotation. That's why
My mom's a preschool teacher, so.
Now I can go see any kid. I can pretty much go to anything except COVID, and I've got a force field. That's pretty amazing. Other questions?
Do you think the COVID vaccine will be something that we will have to get yearly? And if so, do you think they will combine the COVID vaccine with the flu vaccine and be like a 2-in-1 combo?
So one of the CEOs said this will likely be yearly, and I'm hesitant sometimes to listen to what the Pfizer and the Moderna CEOs say because they're very incentivized to say you should get this every year, right? But I also believe that they are trying to follow science because that would really ruin the reputation if they did not. That said, if we're seeing variants that take hold about every 6 months. And if we're seeing big variants that take hold where they're causing so much change where we have to get a new vaccine, the answer is yes. But once you get kind of the operational efficiency up, then you can get more and more people vaccinated. But uptake, so flu is an example. We have to change it every year, right? We get information out of Asia. We think it comes from chickens, or we grow the viruses in eggs, and then we come up with a bunch of different potential strains. already there's in place this big infrastructure for supply chains and sending all the drug out or the vaccine out. That's not really there yet as much for COVID, partially because of the type of the vaccine that it is and how it has to be stored. It's a lot more delicate. So so the answer is it maybe we have to get there to doing it every year, but I don't think it'll be combined, at least in its current type forms, with things like the flu, because they're different vaccines. Now, did I get the flu and the vaccine at the same time I boosted? Yes, one here, one here. But so you can get them at the same time, but they're not in the same.
No, I was gonna say, it's good you got them in two. I got them, made the mistake in the same arm. That was don't ever do that. That was the worst mistake. That was the word flu.
But I do think that we'll probably have to have some cadence of boosters of new vaccine, and whether or not it'll be every 1 year or every 2 years, I have to see. But that's kind of the nature of respiratory viruses versus some of the slower mutating viruses. Like chickenpox, we don't have to get that many. It's actually a respiratory virus. It just causes it to come out on the skin, right? But it does, we don't have to get, a change every year or anything like that.
I just learned about this, that I guess, is it the WHO basically, they research the whole year of what they think will be the flu, the different types of flu. And then they release it on one day, and then everyone knows about it, and that's how they start distributing and manufacturing it. I never knew that though. I thought that was so cool.
Well, the time frame is so contracted.
Yeah.
And what's really interesting, fun, not fun about the flu is flu has usually 2 strains a year, an A and a B. And typically, if I remember correctly, B starts first and then A comes in, or maybe I have it backwards, but it doesn't matter. But there's a competition that occurs between the two, and when the two kind of switches place, and you tend to see a little bit of this different disease profile with it. But it's very contracted and quick. You usually start seeing people get sick in October, November, then the holidays. Because grandma's cool. You can hug her, you can kiss on grandma. She's clean. There's no way she's got the flu. Nope, she's got the flu and infected the family. And then it gets spread all throughout the rest of the family. And then you see this new strain that comes about at the beginning of the first quarter, and then usually wanes about March, April. So you have a very contracted 4 or 5 months. And so you have to get it right, and you have to get it distributed in that short period of time. And you also have to concentrate the vaccinations mostly between the months of September and November. So it's a really, really short period of time. Thanks, folks. Good luck.
Good.